Good afternoon, everyone. This is Lynette Elliott. I would like to say thank you all for joining the call today. It's October 17th, and we are working on food insecurity dataset identification. We will zoom through some regular admin items while we wait for everybody to get dialed in. I see people are still logging in. And honestly, if everybody else's week has been like mine, we're all a little behind. So we appreciate you being on the call with us. We do record these meetings, so we try to cut down on background noise, and you are all entered on mute. But you can use the chat feature to ask questions or to address questions that other people have asked. We've had a lot of good back and forth in the chat for these past few weeks, and we appreciate any of you jumping in to address any questions that come up. This is a community collaborative, so we appreciate you all providing input on that. Please send your chats to everyone so that anyone can address them. If you have not already done so, and you are not receiving emails from Gravity Project at emiadvisors.net, please join the project. This is the list that we use for communications, and you can join as an other interested party or as a committed member, and both of those are described on the Confluence on the Join page. And you can also check to see what your member status is on that same page if you can't remember whether you signed up or which type of member you signed up as. Next slide, please. We have several items on our agenda today, and we will be handing off the call to Linda Hyde here in just a moment. She will go over data element submission statuses with you. And then Sarah DeSilvi will take you through diagnosis and goal submissions that have been received so far for the end-to-end review, as well as a global definitions update and case management CPT codes. This is a new subject, so we will hopefully we will get some feedback from all of you on that following this meeting. And then Lisa Nelson is going to take you through part 2 of the FHIR IG development process. And then we'll go through next steps and set you on your way at 5 p.m. Eastern. Next slide, please. This is our schedule. We are on today, 10/17, and we are working through the end-to-end review sessions. And your homework will be to review the master list items that have been covered so far and to provide any feedback that you have. Next slide, please. And this is our schedule out through November, and it's hard to believe that we are getting so close to that, but we are. Next slide, please. I will hand it off to Linda at the take you through statuses on data element submissions. Linda?
Thanks, Lynette. Next slide, please. Again, just kind of reminder that of the 19 organizations that submitted a file for us for consideration, this just reminds you of how many submitted by the 4 various activity types that we're reviewing. Next slide, please. This should be familiar to everybody. This is our weekly update. As you can see, we have gotten feedback for our outstanding questions on screening tools, diagnoses, and goals. We only have one intervention outstanding question. We did get feedback, which we're going to be reviewing on our call tomorrow. So we should have all of the files completely adjudicated by the end of the week, and we will start or we continue to return those completed files to people at the beginning of next week. Please. This is just a recap again for all of those statuses that are on the previous slide, just a reminder what they are and what their disposition means. And next slide. I will now hand it over to Sarah, and she's going to continue our end-to-end review, going over diagnoses and goals that have been submitted.
Next slide, please. So first of all, I just want to welcome everybody again. It's the team is really excited to keep on going through this work. As akin to last time, I'm going to try to review the process for how to just take note of the current elements on the diagnoses list and the goals list. We did the did the screening work last meeting last week. So snapshot of the master list as it stands right now within the diagnoses tab. Again, there is every single element has ID. You can see, so D for diagnosis, and then we only had 5 submissions there. The number of organizations is the next column. We do try to keep note of this just to show the weight behind different diagnoses. All of these, of course, are going to have food insecurity main, so that column is the same. We then have diagnoses parsed out into whether they were primary or secondary. You all will remember a while ago now, about a month ago, we decided to not address secondary diagnoses at this time. We had a fairly robust amount of nutrition secondary diagnoses, but hadn't really represented the literature regarding the other medical clinical associations of food insecurity. So for phase 1 of the Gravity project, we proceeded with just diagnoses we considered primary. There are some caveats I'll discuss in a couple seconds. The next column is SNOMED codes, and then there's the SNOMED CT fully specified name. There's an ICD code column. Can get a little tricky because it shows the ICD code that's currently mapping to that SNOMED concept, and I have to go through that a little bit on next. And then this final set, this column I and column J, they all correlate to some existing proposed ICD-10 CM codes that we submitted to NCHS in March. So before the Gravity project kicked off, myself and Blue Cross Blue Shield, with the support of many different organizations in the country, submitted request an application for food insecurity ICD-10 CM. So these are the codes that were part of that submission that are relevant to the domain of food insecurity. So they don't exist yet, but they already are. They're kind of in a halfway zone. So we put them over in this column I and column J. So again, to recap, you have existing SNOMED CT. You have existing ICD-10 CM. And then you have proposed ICD-10 CMs. I've put an asterisk on 2 different concepts that are on the master list because during the adjudication process, we had to give a little bit of pause for these, and we really are looking for community insight on these. So when it came time to re-adjudicating the master, because if you can imagine, part of what we've been doing as an internal group and as subject matter experts is applying the same level of rigor to the initial master list that we made, that we've applied to the submissions from the community as we've developed our knowledge. So what we did is we submitted codes. Initially, the Academy of Nutrition and Dietetics and myself, and I worked heavily off of the compendium of social that I helped work on with Siren. And then we re-adjudicated our own submissions to make sure we were ethically keeping and conceptually in line. So these 2 concepts, nutrition impaired due to limited access to nutrition-related supplies, and one of the submissions for the ICD-10 CM, patients' noncompliance with dietary regimen secondary to financial hardship. We left on the submission, even though they're kind of like half primary. So we look forward to understanding that they're not exactly a direct correlation to the concept of food insecurity, but it's difficult to have that without being food insecure. You can't be diagnosed with patients' noncompliance with dietary regimen secondary to financial hardship without some element of food insecurity. I guess that's what we're trying to say, but it's more of a access concern as opposed to, it's more of a non-compliance concern than a food insecurity concern. Okay, so I see a comment down there. Lucy, I'm just about to get to that on the next slide, so that's really helpful. So Lucy Johns has a question, and I'm going to explain that on the next slide. So, but just to wrap up this slide, what I want to say is part of our process of review with the community is really trying to ask your insight on the adjudication as well. So if these concepts don't feel to be aligned or you feel like they shouldn't be on the master list, this is part of our activity. Part of our secondary adjudication, we decided to keep them, but we look forward to hearing what you have to say. The next slide, please, and I'll answer Lucy's question.
Sarah, sorry, just want to chime in as Evelyn. Al also had a question. Are these the Z codes that exist in ICD-10 international, but not in US realm? So the new ones you
Also answered
proposed.
on the next slide. Look at that. Was that L.
Awesome.
Taylor?
Yes.
Yeah. So so anticipating those questions and thankful. So what I tried to do is map out a little rough algorithm of where we stand with international ICD, current ICD-10-CM, and the proposals, and how the SNOMED CT concepts map to the ICD-10-CM currently. So this is a little bit busy, but I'm going to try to go through it from the top down. So you can see there's basically a side of the slide, which is ICD-10, and one column for existing SNOMED CT concept, right? Within the ICD-10 column, the international release, as it stands, this is not ICD-10, this is not ICD-11, this is ICD-10 right now. We have two split concepts, which is 58.6 and Z59.4. So inadequate drinking water supply and lack of adequate food are split. In NCM currently, because of the lack of the Z58 series, these are combined into Z59.4, which represents both concepts. So right now, SNOMED CT concepts of insufficient food supply, the new food insecurity SNOMED concept that we wrote a year and a half ago, are currently mapped within the National Library of Medicine iMagic map to lack of adequate food and safe drinking water. So that is logically, if I diagnose Z59.4, this is the map that would be within the problem list I would have to reconcile. So this is what we have in present state right now. So in blue, what I've done is put the potential new ICD codes, right? So you would have, again, we're asking to mimic the split that's currently international. So it would break out again into inadequate drinking water supply and lack of adequate food. And then a child of lack of adequate food would be food insecurity. That would map to food insecurity as a SNOMED CT. So the mapping would change once we build new content that has more distinct children. And part of the reason why we did this as well is it can be easy to think that insufficient food supply is an access problem. One of our internal team was raising questions about that. It is a non-defined concept, which for right now just is the bucket. It's the non-specific bucket for all things food. So we hope to get it again further clarified through appropriate children, but this is why lack of adequate food and safe drinking water, the concept we currently use for food insecurity, even though it's non-specific, maps to an insufficient food supply, which is also a non-specific code in the current mapping. Any questions regarding this? This is my, again, humble attempt to answer some of the questions we anticipated from the previous slide. Looks like Dylan has somebody has a question. I'm wondering if that one, Donna, those two SNOMED CT codes, the nutrition supply codes, those are A&D suggested. So Donna, do you want to answer that question?
So I don't think that we have one related to insufficient food supply. I'm wondering, is it related to the SNOMED CT insufficient food supply?
Supply.
Oh, related. Oh, okay. Related to, I'm sorry. Yes, yes. So the food and nutrition supplies relates to individuals who have difficulty accessing, for example, maybe enteral nutrition products, bags, tubing, nutrition supplements, those kinds of things. Typically, the people who maybe fall through the cracks and don't qualify for medical foods.
Thank you. And I hope so. This is like, so does that help answer the question? And then just to go back to, was that someone named Dylan? Is that helpful? I'm just going to assume that it is. And then please let us know if our questions are not answering your concern. Jane very elegantly points out um, Jane very elegantly points out that the SNOMED has many water codes. Yes, 100%. I did not delve into them at this time because food insecurity is the concept of concern. The reason why I included the water elements was because of the clumping of Z59.4 within ICD-10-CM. And so I wanted to show how, in order to address that concern in our application to NCHS this past spring, we broke them out. And that would again allow for better mapping of water concerns within SNOMED as well, within US use. And it looks like Dawn has answered a specific question regarding genetic concerns for Dylan. All right, next slide. All right, so pardon the granular nature of this. This is again clippings from a very landscape view summary. It's very long and skinny. So this is our snapshot of the goals summary. So this is the goals tab of the master list. You can see we have 5 goals that were brought to by the community. So we have food security as a goal. And then again, you have the column, the ID column, G for goal, the number of organizations, the concept, the goal description, and the goal type. And the reason why we included this is because some of these are individual measures and some of these are population measures. And sometimes they can be both. And if we didn't do both appropriately, we can have comments on that as well. Some of these things are difficult to measure as a community population base, so that's why we might have focused just on the patient. But again, they are food insecurity screened, which is its own measure, its own goal. And then we created a goal for food insecurity screened and intervened, and this is based on an ECQM CMS measure for depression screened and intervened. So the intervention possibilities really are so robust as akin to the depression screened and intervened measure. We have a goal of decreased severity of food insecurity, and I'm going to go into a little bit of that on the next slide, and the decline in prevalence of food insecurity. So you can go to the next slide. So we thought it would be wise to do a little bit of definitions here. So prevalence is the rate of food insecurity in the population, the number of food insecure individuals over the total population measured. For all of these things, we're really basing our definitions on just on the use of validated core scales. And when it comes to severity, you really have to be using, right now in present state, the full robust food insecurity screeners like the USDA tools, the HFIS, which is an international tool, and the Food Insecurity Experience Scale, which is a World Health Organization tool. The reason why is very few of the initial screeners that we have and some of the disseminated tools nationally give you enough information to categorize severity of food insecurity. So it'd be again akin to depression, where you might screen with an initial PHQ-2 and then default into a longer assessment to understand the severity of the concern. So most commonly, the categories of food insecurity severity are mild, moderate, and severe. And there's a little caveat here. So although each tool has its own scoring criteria, the USDA very sophisticated scoring criteria that includes the never true, sometimes true, often true, and don't know or don't want to answer elements. So you get this, you get a temporal element of that as well. The HFIS and the FHIR are a little bit different. So, and then the USDA tool includes a child element when it does a household screener, and these other tools do not offer that as well. Although each tool has its own scoring criteria, and although there are variations that account for cultural interpretations, like the FHIR tool has the order built a little bit differently in their deep qualitative studies of how food insecurity is experienced in different cultures. The most important thing to understand when it comes to severity assessment is there really are commonly understood severity themes that define the continuum of food insecurity across different cultures. So This all comes out of early work within the US. It kind of grounded on the work of Ratimer, Olson, and Campbell in 1990. And this work basically became the USDA tool as we know it. So the food insecurity continuum starts with worry about not having enough food, and you'll recognize that concept in the first question of the hunger vital sign and the USDA tools, and each of these tools actually. Level is decrease in the quality of food. Then you go into reductions in portion sizes. Then you start skipping meals, and then you go for 1 or more days. So as I mentioned, each of these tools has a quantified set of how the questions answered correlates to severity. The USDA screener has it all laid out. So depending on which tool you're using, each has a very clear way how to assess severity. So I'm not going to go into each of those at that time, but know when it comes to meeting the goal of decreased severity of food insecurity, this is the kind of thing we're talking about. This is well understood, of course, in the world of nutrition as they do this in-depth assessments of food insecurity as part of their work. Any questions on this page? Okay, on to the next slide. Just wanted to give some hope here. Oh, it looks like let me see if I can answer that question next, Lucy. I'm happy to. So I wanted to give a little bit of hope here, just some references for how some of the different interventions that we're talking about have actually decreased the prevalence or severity of food insecurity. So there's just some lit from my lovely friends at FHIR and Children's Health Watch, SNAP and WIC. And then there's some literature about home delivered meals and medically tailored meals. I do want to stress that, once again, I got my little soapbox here, that part of the reason why the USDA is so dearly cares about assessing food insecurity is it's a wing of their interventions to address food insecurity and hunger through food stamps and the WIC program. So evaluating the effectiveness of SNAP at addressing food insecurity is a deep concern to the USDA. So Lucy Johns asked, what if the patient has food insecurity because they're feeding the family or children first? This is actually a known concept within food insecurity, so thank you for addressing that. It's contained within the severity assessments within the full USDA scale tool. If you use the full USDA module, you will be able to address that quite clearly because it has different questions for the caregiver and different questions for the children. And then those assessments of child food insecurity versus parent food insecurity contribute to the severity assessment as when you use the tool. And just as a note of, like, I was thinking about this in the last night late, we get a little scared. It gets a little scary using household tools to assess individuals in clinical settings. This is the world of pediatrics all the time. So if I'm taking care of a 5-year-old patient, using the USDA module to understand the experience of food insecurity in that family is 100% appropriate. It's akin to the CPT codes that we use for health risk assessment. And we do know that food insecurity screening correlates with that use because you're basically assessing the risks of the caregiver experiences for the benefit of the patient, who is the child. Did that answer your question, Lucy? Maybe. I hope so. And if not, I'm right here. Okay, next slide. So again, just wanted to show everybody how to submit end-to-end review comments. You're going to download the latest food insecurity master list. You're going to again email comments regarding data elements to Gravity Project. We really want to stress again that you have to include the ID. We want to understand whether you feel like the concept should not be part of the master list, whether it's not appropriate for food insecurity. And we want to know if there's concepts that are not on there that should be. Right, so we're amassing a sum total. We're kind of building the master as we go. So screening, diagnosis, and goals, interventions are to come. Please include a description for the data element you propose. For the screening element, attach a copy or link of the screening tool. You are adding something new, right? So include a description for the data element you propose to include. And for any screening element, do attach a copy or link to the screening tool. I do just want to give an update. So I did, as I promised I would, I did add links to all the screening tools we reviewed in the last meeting to the summary page, and then we're working on building them into the Confluence site as well. So comments regarding diagnoses and goal submissions, please get them in by October 30th. Okay. Matt asked a quick question about on the literature on interventions that you can point to that relate to how they impact value-based care metrics. So yes, actually, there's a fair bit of literature growing, especially within the medically tailored meal space. Been wonderful partnerships within MANA and Humana and Community Servings and Seth Berkowitz, detailing decreased readmissions in the presence of medically tailored meals use versus home delivered meals use in dually insured individuals, then decrease total cost of care and improves outcomes. There's also, when it comes to MIP measures, diabetes poor control. Hillary Seligman has an amazing work with Feeding America on interventions in food banks with specialty geared diabetes associated food packages and the effect on A1C. So there's a lot of data. All right. So next slide. We're now going to segue into a new topic, which is really an update on what I'm calling the global definitions. This into like a brief introduction into a process that we're currently involved in trying to address a concern with our definitions of food insecurity. They stood at the beginning of our project, anticipating a need to revise them for the eventual value set. So I describe the problem here. Although the definitions as they were published from the US and the World Health Organization were conceptually sound, the definitions had a couple problems. Number one, most of them are population-based. Both the food security definitions from the World Health Organization and the USDA are population-based and don't describe the experience of the individual. And they also did not allow for computable logic. They weren't clear, the concepts weren't clear enough, and they weren't relatable enough to be computable within the value set. So you can see a really good example of this is the difference between the USDA definition for food security at the top of a very busy thing on the side versus food insecurity. So you have the food security definition with the USDA was accessed by all people at all times to enough food for an active, healthy life. That came out of early 1990s work by a group called the Life Sciences Research Organization, really foundational concept work regarding food insecurity. But their food insecurity definition was limited or uncertain availability of nutritionally adequate and safe foods, limited or uncertain ability to acquire acceptable foods in socially acceptable ways. So it was difficult to plug these definitions into a value set model, again, because they were not population-based, and the way they were written didn't allow an easy logic. So we have been undertaking a really interesting, robust process to try to get to definitions that we can use for this work, and it's been fascinating. So the way we've done that is to do a collective literature review. Donna and the American Academy of Nutrition and Dietetics and myself and all kinds of food insecurity content experts that I know, and our internal Gravity team, and the wonderful knowledge of Monique Van Berkom and Corey Smith from the American Medical Association. We basically have been revising and massaging these definitions over the last 2 months. When we get to a good point, we will present the definitions as they stand to Gravity for consensus. In respect of the facts that because we're using international lit and lit, we are working with the World Health Organization and the USDA, and then this wonderful author Jennifer Coates from Tufts, to try to make sure they're okay by the USDA and WHO and COATS before we present them back. But we just wanted to let you know that this was work in progress. I just want to briefly give a nod to Jennifer Coates, because a lot of the literature we've had to use in order to create these definitions is the literature of measurement. And she wrote this really wonderful paper in 2013, and Dr. Coates, entitled it "Build It Back Better, Deconstructing Food Security for Improved Measurement and Action." And she clearly delineates the measurable components of food insecurity. That it's a really lovely pseudo definition for this work. So we have been revising her concepts, and hopefully we'll meet with her soon. So this is just a rough view of the work, and folks from FRAC and Children's Health Watch and Feeding America, and then founding researchers at the USDA and food as medicine folks and food bank folks, and I have been having these little hash sessions, and Anna's been working with the AND, and it's been really fascinating. So we're getting there. And then when we get to something, we're going to bring it back to you guys and see what you guys think. But we didn't want to keep on going with that work without touching base. Any questions on that? It's big. And then understand that if you have any questions regarding after this meeting, email us. I would be happy to answer any questions. We'll be happy to rope you into that work. It's interesting how important this is, and it gives us a really good example of how we're going to have to apply similar work to the future concepts as we go forward. Okay, next slide. Another little thing that we didn't anticipate. So as we were preparing to deliver the interventions to all of you for review, we realized we had really robust presence of nutrition assessment in CPT, but even though we've been talking about case and care management and care coordination, and we have built concepts to address the activities of case management and care coordination, we did not have any submissions that included the billing that are appropriate for those activities. No one in that internal group, a case manager, a care coordinator, a care manager. So we humbly recognize that we are not experts in this space. So we are seeking help in this. And so we know that we have these tables that we're going to publish on the Confluence site that include some of the codes that we know exist, and these are CPT and HCPCS codes. We're asking you to do some homework, which is review the list of case and care management applicable codes on Confluence. And the link is right there, and then send your feedback to us to help us inform our conversation on October 24th. So all we're asking you to do is look at the table that we have published on Confluence, identify some of those codes that you feel like are essential within the master list intervention tab, and then prior to the meeting on October 24th, so we can use that in our discussion on the 24th. And if you have any questions about that, let us know. So basically, we have for activities like the dietitian nutritionist, we do not have CPT right now for case management and care coordination, and we feel like we need to include it. We just don't know which ones are important. Okay, questions. It looks like Lucy Johns has another question. Orgs you've consulted with feel represented in the gravity process. Are there others also trying for more uniformity in other ways? So I would say so far, the orgs I'm working with feel like gravity is the best way to feel represented. I know it gets overwhelming. The gravity process is new to all of those of us who work in the trenches in the subject matter world. And so, I mean, just thinking about terminology this deeply is new to many of the folks who are on the ground. But I do feel, and I don't know if I want to speak for everybody, I think probably some of my friends in that space are on the call right now. This is the only way I've heard that folks are looking for uniformity in the data. Many organizations across the country are looking for uniformity in process. uniformity in referral process, uniformity in assessment process, and implementation science. But insofar as the language we use to name what we're doing, as far as I know. Questions?
This is Evelyn. I just want to add or piggyback on your comment that, let our community, we have very large community, and as you mentioned, it could get overwhelming. And we know that there's so many efforts happening nationwide. So we also look to our community to let us know if there are organizations they feel should be included or we should do outreach to. Please let us know, because that's how many of you have also joined us, because somebody connected us or some entity felt like, your entity needed to be involved. And so we've gone out and reached out to you to invite you to participate. So we need to continue doing that and hear from everyone, because I know often if you just think this is a terminology project or a standards project, interoperability project, you might not think how relevant it is for your day-to-day work, but it is, and we want to make sure we hear from you. So please do continue letting us know who we should be reaching out to if you do not see them engaging or providing input.
Yeah, and I just want to echo that as well. So I guess I might have interpreted the question wrong, but the more on the ground folks we have who are shedding their wisdom into this project, the better. We do try to reach out to the community. Like I have little side emails when I feel like there's an echo chamber that I need insight on, but I would love to have we need as many content folks and real users as part of this community as possible. This work actually represent the way you're caring for patients and people and your neighbors in real time. I think probably we're ready to segue into the next bit.
I'm going to hand it over to Lisa. So Lisa, have you been able to connect? I know she was having difficulty.
I am okay, connected. Great. I have skedaddled over to a neighboring state to escape a large blackout in Rhode Island, and I was able to get on the internet. I'm feeling a little insecure about sharing my screen, Evelyn, so I think I might just work with the slides that are present with a next slide, or have you already given me control?
No, I haven't. I could do that. I have hyperlinks for all the slides you're presenting anyway, so if they want to do a deeper dive, they're all there.
Okay, so we'll just try it this way, and I'll just go with next slide. So this is the portion of the weekly meeting where we promise to expose this entire community that might be finding it new to be thinking about terminology, to also have a chance to think more about data structures and some of the work that gets done at a deeper level in the standards development space. So this is your exposure this week. We're going to talk a little bit more about what are FHIR resources, what are FHIR profiles, why do we need them, and how does all that relate to this Gravity SDOH for clinical care implementation guide that we're starting to work on. Next slide. As we talked about last week, this effort is a FHIR acceleration project. So we are working on taking all of our definitional work, like Sarah just talked to you about, in order to use it and figure out how to apply it within the context of standards, specifications that are being developed around the FHIR standard, so that we can contribute this kind of data to larger efforts that are going on in, for example, the definition of US CDI profiles, some of the work that's going on with exchanging information with EHR vendors, payers, et cetera. Next slide. The premise that we have is that we will not reinvent wheels that already exist. In a way, this is harder. It's harder to pick up work that's already done than it is to invent your own stuff. But this is the behavior that we have to have if we want to scale, if we want to have interoperability, we have to be committed to the idea that we will reach to understand what's being developed in other places so that we can make use of it rather than working in silos. And so part of what I'll do as the examples that I show and the way that we learn more about FHIR is we will be exploring some of these other areas that we need to understand more about, know more about. We mentioned that not everybody in this community is going to be at the same level of understanding or really need the same level of understanding of these specification details. So I'm hoping that everyone will be able to listen and learn at the level that's right for them, maybe so that you would become a conduit into others in your organization to know when it's the right time to pull in a more technical resource or the right time to just re-engage, because as Sarah showed, the definitions, the connecting this work into the real care that's going on in communities, we cannot do the technical specifications without having that part. So even though we'll be in the weeds sometimes, we need you to be present and to be contributing so that we can make sure that everything that we develop is really relevant on the exterior and on the use cases. So when we dig into creating profiles to represent, for example, a food insecurity observation, it's really important that all of those definitions that Sarah was talking about, that all of that is founded and we've reached consensus as a community so that the technical standards that we invent will really be applicable. Next slide. When we talk about that observation, I just wanted to remember as we start digging into some of these details, we established a framework that all of you are familiar with in this cycle of care, and now we're going to start creating technical artifacts that allow the data to be represented as this information is collected so that we can move into coding. Clinical observations you see at about 1 o'clock on the clock there, that is an observation where a clinician would actually, after screening, sit down and look at the information, talk with the patient, and in a clinical care setting, make an observation about whether or not that person does have food insecurity. Next slide. FHIR, as a standard, last week we covered, it stands for Fast Healthcare Interoperability Resources. It is a very robust standard, but I like to explain it as providing predefined data structures for us. And this main landing page of the FHIR specification, if you go to hl7.org/FHIR, you see some of these prepackaged data structures organized in different areas like clinical information, diagnostic information, medications, workflow, financials. All of these different categories, you can sort them alphabetically, you can look at them in groupings, but they're resources that are available to us to be able to make our work easier. For example, if we were going to model or use something that was an observation. Next slide. I'm going to show you what one of these resources looks like. The spec is all online, web accessible. You can just click in and see definitions like this, which tell us, looking at the tree structure on the far left, that an observation can be represented using many different pieces of data that would be recorded. The specification tells you whether that element of the observation is repeating or not. It's what the cardinality is. It gives you definitions. It describes some of the concepts that may or should be included in there. If you go to the website and look at this, you'll find that the observation resource actually goes on for 3 pages if you scroll through that. And the groups that work together to define it put a lot of thought into everything that might be needed when representing an observation. But that isn't everything that we need. As we look at something specific, like an observation about food insecurity, we may only need parts of this model for what we need to represent. Next slide. So the concept of a profile, a FHIR profile, is the guidance that tells implementers which of these parts and pieces from the observation model are needed to represent a specific kind of information. The profile example that you see here is a built-in profile around body weight. I like the way Sarah says there's something to be hopeful about, and there's something to be hopeful about here because instead of having 3 pages of possibilities, the observation profile for body weight includes a code and a value quantity. There's additional information about the coding of that code and what value the value quantity might take, what systems need to be able to support. But for the most part, this is a pretty easy constraint on that general observation. So that's what profiles do for us, is they give us these very specific recipes of how to use some of these default building blocks that FHIR has given us. Next slide. So now you have been exposed to the definitions of resource and profile. Let's talk more about what an implementation guide is, or some of these specific profiles that already exist. The family of profiles that are called US Core have been developed to line up with what the ONC has defined for us in the US Core Data for Interoperability, or US CDI. So in the background, maybe unbeknownst to some of you, a group of people have been working on making sure that we have profiles already established for all of those core data elements that have been identified for interoperability. This collection of profiles, on the next slide please, is represented in a FHIR implementation guide. Oh, I'm going to skip the, just because we're short on time, skip this, the digging into the goal, resource, goal, profile, and let's talk about implementation guides. Right now, there are hundreds of implementation guides that have already been developed for FHIR. And it's a great library of resources that we can make use of. US Core, right on the top of the list there, is the one that I was just describing for you. And so if you go into the FHIR registry, it's just like a library card catalog. You can get access to all of these different IGs that are holding profiles. Next slide, please. When you think about an IG, I think that's the best way to think of it, as just an IG is a home where profiles live, and it's a place where you get more guidance around how to use the profiles in order to accomplish certain use cases. So there's narrative like this. You'll see there's kind of a home page. It looks just like a website, and you get a lot of overview, introduction, stuff that you can really read almost like a book to tell you what to do. And then the third tab on the top gray bar at the top, where it says profiles and extensions, that's where you click to get brought into these more technical specifications about how to use the different data structures. Next slide. So there you go, FHIR IGs, a place where FHIR profiles live. And the US Core profile is just undergoing an update right now. I still encourage you to go out and look at the US Core profile. If you're interested in learning a little something about FHIR, it's a very good place to start because there'll be a lot of recognizable profiles that you can begin to be exposed to. And many of the other IGs are utilizing these core building blocks of data element definition. Next slide. The IGs that we are going to be building to represent social determinants of health are envisioned to be a large collection of work. You know, as a community, how big this topic, how big this subject is. And we're getting started in a real small place, the clinical care setting with 3 use cases around just 3 domains. So our initial work will be focused in one IG to bring together the stuff that we've been doing over the past few months and the data definitions that we'll be working on together over the next couple of months. But we do envision that over time, other IGs in this space will be developed that can cover other clinical settings or other care settings, even in the community setting, and that over time we will be promoting some of this content into a higher level, what we would call an overarching core technical spec, so that we make sure that things that we are doing, even within the SDOH space, that we're reusing as much as possible and making sure that we remain aligned by promoting common things into the one guide at the top that people can be exposed to first, and then we get into the specifics that are different at the use case level down in the specific guides. So this is just a little bit of a vision about where our IG collection will grow to over time. Next slide. We're using a tool to develop our implementation guide, just like somebody would use, let's say, what is it, WordPro? What is the website development? WordPress, sorry, WordPress to create a website. It's a tool that helps you make pages and lay out widgets around on your website, link pages together, etc. WordPress is to developing a website the way Trifolia on FHIR is to developing a FHIR IG. It's the tool that our group will be using to make these technical artifacts and lay them out so that the community will end up being able to read this work just by going to a simple link. And each week as this work develops, I'll be showing you a little bit more and a little bit more, so that instead of just feeling like it's an overwhelming process at the very end, if we ask you to look at the IG and review it, instead we'll be growing together incrementally, starting with how do you get into the implementation guide, where do you go to see it, how is it laid out. We'll be stepping through that a little bit each week, so stay tuned. You can invite other folks from your organization if you feel like this part of the call is a little bit more technical and you want to expose them. We'll probably have at least a few minute segment every week on building up the implementation guide. Next slide. So look, I'm preceding myself. This is going to be an incremental process. We are hoping that over time, just as you're exposed more to some of the terminology, concepts, and the technicalities of developing codes to go along with certain informational concepts, you'll also be exposed and learning more about FHIR and what it means to develop a FHIR IG. We'll be probably coming to you with some design choices, just like your homework, to help us understand some things we need to figure out around definitions and around codes for care and case management and care coordination. There may be parts where we reach out to the community and say, we have a design choice to make here. Should we go left or should we go right? And that's why we need you to continue to be engaged. We will be looking for review and feedback so that you can contribute comments to this. This is how we get collaboration and consensus around the specification that's being developed. And we'll also be exposing you to something called Connectathon, which is the testing experience that a community goes through to confirm if the specifications that are being developed are sufficient, are fit for the purpose to really help us do the use cases that we've established. So there's, you know, it's a foreign experience. There's logistics involved. There's how do we get our systems ready? What will testing, hands-on testing be like? How does one go about developing a FHIR application interface for a client or a server type system? We'll be covering a lot of that so that you can grow in your comfort with being able to think about that, figure out if your organization is positioned to participate and what role you might like to play. We'll be covering that during the segments of the call as well. And it's very important that we do this level of testing because interoperability is not something you can just make happen on paper and read about. It's a very experiential thing to prove out that one computer can communicate with another computer without having to have the humans make it work, but that you can build things based on a specification and you can anticipate receiving information based on a specification and know that what transfers in the middle is going to be what's expected. That kind of consistency and anticipatability about data is what developing specifications like this really do for us. Next slide. Evelyn, I'm going to turn it over to you. I'm looking at the chat window and to see if I missed any questions.
Yes. Let's pause for questions. Lucy is asking, will you follow up with us with links to these 3 bullets so we can start to participate? And that is in, so that's anticipating our next slide here. We have a link, we have a page on the Gravity site where you can sign up for testing if you'd like to test or if you'd like to learn more. So we can, we've got a few, this is Evelyn, if we have a few more minutes, so we can also pause right now and take any questions regarding any of the FHIR work or any of our homework that we have. Any comments from the community today?
I just want to, this is Sarah De Silva. This is not a comment, but I want to just continue to say thank you to all of you for being present for this work and for all of your insight. We remain very grateful for all of your participation. So just a community thank you.
Could you possibly, this is Lucy, could you possibly send just this next step slide to all of us as an email so we can go directly from that email into these links? Would that be too much to ask?
Thank you, Lucy. We usually send a follow-up email Friday, just acknowledging recap and with homework and links. Okay. So when we
Great.
post also the slides for this meeting. Okay, and this is Evelyn. Just to clarify too, I know last week we talked about screening, the screening data concept, and we had asked for your feedback by next week. And now I think we had, so there's an error. Just want to clarify that we're asking for diagnoses, screening. We have screening data element review, but we also have diagnoses and goals, and the screening are presented in the summary list. And our diagnosis and goals will be included in an update master list that we will publish tomorrow. Any other questions or comments? All right, well, if there's no questions, again, thank you so much, everyone, for joining us today. We really appreciate your time and your interest. Please let us know if there are other folks that we should be inviting or including in these meetings, as well as any other relevant projects. We still continue with our environmental scan. We have a page dedicated to relevant work. Please let us know. So with that, thank you very much, everyone. We'll talk to you next week.